Please start, ma'am. We are live.
Yeah, sure. Namaskar and good evening, everyone. I welcome you all for today's live webinar on Oncology Perspective 2024, How We Have Moved Forward. Clinical updates in lung, breast, GI, and geo cancers. And with great pleasure, I would like to invite Dr. Devesh Goyal, who is consultant medical oncologist at Fortis Hospital, Jaipur, for the welcome and introductory note and to take the proceedings further. Over to you, sir.
Thank you. So myself, Dr. Devesh Goyal, and working as a consultant medical oncologist in Fortis Hospital, Jaipur. So we are starting the 2-day the conclave of this Oncology Perspective 2024. So how can we move forward? So in 2 days, we discuss about the lung as well as the breast and GI and GU cancer. So first day, we are on the part of this lung cancer. So we will our thought to how can we manage the early lung cancer as well as the role of various mutations. So we included panel discussion as well as the various talks about the various topics in this today 2 hours the talk. So for the first talk, so I invite Dr. Priya, who is consultant thoracic surgeon from the Department of the Surgical Oncology Asian Cancer Institute, Mumbai, and she will moderate a panel on the management of early stage lung cancer. So the for this panelist is the Dr. Gaurav Goyal. He is from the HCG Cancer Center oncosurgeon, and the Dr. Prashant. He is also the oncosurgeon from the Bhagwan Mahavir Cancer Hospital. Dr. Ananya Parikh. She is consultant medical oncologist from the Renova Cancer Center, Jaipur, and Dr. Arundhati, and she is also the pathologist in this precision lab from the Jaipur. So welcome to all the panelists and the moderator. Over to you, ma'am.
Hi, thank you everyone. Good evening. And last year we were in Jaipur doing this conference and a similar conference, and this time we are in online, and that's nice.
Yeah.
Can I just take the control of the slides myself?
Vishal.
Yes, ma'am, we are.
Yeah, Vishal, what did you say?
Shan, come again. Ma'am was not able to hear.
Yes, ma'am, we are trying to give you control.
Okay. If you want, otherwise we can start off. No issues.
Okay, ma'am, we are not able to give you control, so we can start.
No problem. Yeah. So good evening to all the panelists, and today we are going to actually start off with the panel discussion on early stage lung cancer. And we all know that it has become a very different kind of cancer to treat nowadays. So can I have the first slide, please? Slide change. Yeah. So early stage lung cancer, not to waste any more time, we are up to 3A. That is, would go up to T4N1, that is operable. But we would not actually go on to so high, because let's focus on things which are a little less bigger and more confusing for all of us. Next, please. Next slide. Yeah. So the first case I would like to discuss is a 45-year, the previous slide. The first case is a 45-year-old male who's a non-smoker. He's hypertensive. He had a routine health checkup done, which showed an incidentally detected small space-occupying lesion in the right upper lobe. Next slide. So what investigations I would plan next? I don't have all the names. Dr. Prashant, right? One who's oncosurgeon from Bhagwan Mahavir Cancer Center.
I think, ma'am, Dr. Prashant is not here, as well as the Dr. Gaurav is also not here.
Okay, so who else are there? Can you just give me the names so I can just remember them, because it's
Dr. Ananya as
and
well as me.
unfortunately it's hard. Okay, Dr. Ananya and you. Okay, so I actually started raining very heavily in Bombay, so I had to leave, and that's why I'm standing on the side of the road and doing it on the car, from the car.
No, ma'am. Absolutely no worries, ma'am. Good evening.
Yeah. Good evening.
And
So can I he's already gone to the next slide. So investigation wise, Dr. Ananya, would you do an MRI brain for this patient if it's a very
ma'am, I
small
think
lesion?
yes, ma'am. It's a very small lesion, but I think MRI brain should be done to rule out any brain metastasis, so that like exact treatment should be done, and PET scan should be done
Okay.
for
Okay. Next slide.
extrathoracic.
Ma'am, I think just I can add. Can I take the
Yes, yes.
decision of
Please,
MRI
please.
brain? Can I
Yes, sir.
take the
Yes,
Yeah,
sir.
decision of
Please, sir.
Tell
yeah?
me.
Please.
Tell me.
So
Tell
can
me.
I take the decision of MRI brain after the PET CT report?
Yes, you can. Yeah, why not? But the only thing is that I guess Dr. Ananya was trying to say is that even if it's a very small lesion, nowadays we are seeing a lot of non-smokers having silent brain mets, probably.
Yeah.
But yes, let's start off with a plain CEC first. So this was a CT scan of the patient who had a very small nodule which was picked up on the right upper lobe. And this was followed by a PET CT scan. So the next slide, please. There was a small 1.5 by 1 centimeter lesion with speculated margins, no nodes on the contrast, media channel nodes. So next slide. Do you do a biopsy for this patient with a CT, Dr. Gaurav? Would you go first? It's 1.5 by 1 centimeter lesion. Would you go for a PET first or do a biopsy first? Or would you not do a biopsy?
Ma'am, Dr. Ananya?
Yes, sir.
Hmm.
Sir, I
Dr.
think
Ananya,
PET
what
should
would
be
you
done. PET should be done first to see the most approachable site, and if there's no other lesion and this lesion is very small, so I think biopsy is not required. Matlab, if PET mein SUV is high, then I think we can proceed with this. I'm not the person to say this, but I think surgery should be done.
And Dr. Gaurav, what would you ask your patient if you have such a patient?
I think, ma'am, actually, still, I'm Dr. Devesh. I think PET can be done upfrontly so that we can
Yeah.
decide, so that we can decide
Devesh Goyal,
after
yes.
this whether the size of this nodule is very small, is it biopsyable or not? So we can decide after the PET CT report.
Okay. So can I have the next slide, please? Next. So we did a PET CT scan for this patient first. Next, please. Next. This is without any, I mean, this would actually was for a bigger, with surgeons included. But since we don't have them right now, let's go to the next slide, please. We have decided we need to do a PET CT for this patient. Next slide. Yeah, next. So only problem in PET CT is the possibility of a tuberculosis. But definitely the SUV value as well as the clinical characteristics of the imaging characteristics of the lesion will give us a little more idea about what kind of lesion we are facing with. The only thing is it's sometimes incorrectly upstages some diseases like N2, which is again endemic because of tuberculosis, as well as if what if it's tuberculosis and we'll end up operating the patient, and when all it could have probably needed was a AKT. But 1.5 by 1 centimeter is a place where even I would prefer to do upfront surgery and not a biopsy. Next, please. Yeah. So false positive rate, as we all know, is around 55%. But it is good for at least a primary to see rule out any extrathoracic spread, any stage 4 lesions, to get an idea about size as well as the mediastinal lymph nodes. Next, please. Yeah, so this was a PET CT of the patient. Again, it was a very small lesion in the right upper lobe. There were no nodes on the PET CT scan, and there was no other metastasis. So do we agree to do a biopsy first, or do we agree to do an upfront surgery first? Dr. Ananya?
Ma'am, that's a very difficult question for me. But
Not
as you said that
yeah.
you will go
Okay.
for the surgery, so I will say that yes, surgery should be done.
And Dr. Dipesh,
No,
what do you
actually,
what would you suggest?
yeah. Just I think we can discuss in the multidisciplinary team. So I think all are agree
Okay.
on this part. So definitely we can go on this surgical part because it is the medical legal issues why we are doing the surgery without biopsies. So after the MDT discussions,
Without
so we
biopsy.
can go upfrontly on the surgery.
Okay. Next slide, please. You've done a PET CT scan. Next, do you want to do anything else or pre-op investigations directly? Any role of invasive media channel staging for this patient? We
Ma'am,
don't
I
have a
think
biopsy in hand.
in stage one, I'm not sure, ma'am, but from stage two, definitely mediastinal staging should be done. And as we can see in the CT scan, in the PET scan, there was no nodes involved.
Onwards.
So I think in
Okay.
stage one, we can skip mediastinal staging.
Fair enough. Dr. Dipesh, I think you must be agreeing with that.
Yes,
Very
yes.
less than 2 centimeters. Yeah.
Definitely.
Next slide, please. Yeah. So as this is like generally a surgeon friendly question, that whether you do a biopsy, a media channel staging for something which is less than 3 centimeter. Next. So we would also not do unless it's a central tumor or T2 onwards. The risk of occult nodal involvement is very less. So if you have if these two things of central or else T2 onwards, it's more than 10%. So we would still go ahead even if it's N0. But for this tumor, which is just 1.5 by 1 centimeter, invasive media channel staging is not warranted, even if we had the biopsy in hand. Next slide. So again, same thing. Next slide. Next. For this patient, we did not do because of these two reasons. Now, when we go in and operate, Dr. Dipesh, do you have a frozen section which you keep at on standby for these patients? I mean, surgeon nahi hai mere paas koi abhi aur. Okay.
I think
Aap बताइए.
provision sections will required, I think.
Mandatory, I guess, because we would need to have the primary diagnosis as well as the margins if you're contemplating segmentectomy or sublubar resection.
Yes, definitely the fusion is
Next.
required, I think, in my view.
Required, yes. Next slide, please. So traditionally, we used to have lobectomy as the suppose if I have done a biopsy and now on table the frozen is showing adenocarcinoma. So would you recommend for a 1.5 by 1 centimeter lesion, you would recommend a lobectomy for your oncosurgeon in your MDT, or would you be okay with a sublobar like a segmentectomy?
I think, ma'am, the size is very less. So I have not seen the lesser size tumors in my practice, even in 10 to 15 years. So very less size tumors I have not seen. So I think I have seen still the bigger tumors. So I think lobectomy can be done, I think.
Okay, let's go to the next slide. We'll just go through the little bit of evidence which is changing. Yeah. So the first thing, yes, we had the first gold standard was lobectomy. Then there came a meta-analysis in 2017, which was tending towards the idea that survival is not inferior in segmentectomy, not wedge resection, but we did not have a randomized control trial. Next slide. Yeah. So then this trial came up. And this trial came up in 2022 actually, which proved it was a randomized control trial, and it proved that segmentectomy should actually be the standard surgical procedure rather than lobectomy for patients with small size less than 2 centimeter and N0 peripheral NSCs. So this is the first trial which has come in 2022, which has at least till now showed a 5-year relapse-free survival is same, and patients were actually better in the reduction of mean forced expiratory volume. So recovery was better, and the survival was, in fact, not at all bad. It was similar, and patients were doing much better with segmentectomy. Next slide. So in that patient, we a lobectomy, in fact, because that was, we also follow your guidelines of doing a lobectomy. We would prefer to do a lobectomy, man ki shanti hoti hai. So we did a lobectomy for the patient. He was N0, T1, and he did not require anything, T1B, N0, did not require anything adjuvant. So a short jump to the next case so that we have more involvement by you. 68-year-old smoker, 25 pack years, hypertensive, has history of angina, blood thinners. In 2015, he was diagnosed to have a creatinine of 1.7. He had renal stenting done because of stenosis. Creatinine normalized, and July 2015 was normal. Again, years routine investigation showed a left kidney 3-centimeter lesion. With incidentally was detected to have a primary second malignancy in the right lung lower lobe 3.9 by 1.5 centimeter, which was also associated with ground glass opacities because of smoking. Next slide. A PET showed, next slide, I'll show the photos. So this was a left renal lesion and a right lung lesion, around 3.9 by 1 point, where I've mentioned. Next slide. And it had multiple GGUs, so it was a poor lung. So what do we do next? What would you recommend for this patient now? He's smoker, he's got bilateral renal stents, he's angina, and he's got primary dual malignancies.
Just want to add, in this case, the renal mass is the biopsy proven renal cell carcinoma.
Yes,
Yeah.
yes.
So second, just we want to rule out whether this is the metastatic or second primary.
That also
So,
done. That also done. Next slide, please.
Okay.
We'll just do that. I'm giving you 2 malignancies. True cut biopsy from the right lung nodule is of lung TT1% positive. Next slide, please. And the left kidney mass is showing clear renal cell carcinoma grade 2. Next slide. In this, I guess we'll do an MRI brain.
Yes, ma'am.
Would an MRI brain for this patient? Dr. Goel, you would do an MRI brain or you would not do an MRI?
yes. No. I will do MRI brain.
Okay. So now in this patient, sir, would you do a mediastinal staging?
Actually, what in this patient, multiple comorbid patients. So what is our goal? Whether to operate or whether to treat with other modalities. So I think there is the two separate points, the renal cell as well as the lung. So is the patient fit for the two surgeries, the radical nephrectomy as well as the radical lung surgery in this case?
Okay. So next slide. Let's discuss that. Suppose if patient is medically inoperable, as you said, like suppose if he's not really fit, and you plan to give him something else like an SBRT, but how would you do that without understanding the mediastinal nodes are positive or not? That will change the intent of your treatment.
Yes. So we can do the mediastinal staging. Yeah. So this staging will help us to decide the treatment.
Know which intent of the treatment. So curative, or whether we want to take it as CTRT, definitive CTRT or SBRT.
Yeah.
Or surgery. So let us, in this patient, we let's see surgery fitness abhi aayega aage.
Okay.
We are surgeons, hum log nahi chhodte. So this has a level 1 evidence definitely that we should have a mediastinal staging for this patient. Next please. Next slide. So initially, as we know, the guidelines algorithm was that we do a EBUS, and that got established in 2016 onward. in fact before then 2010, but 16 onwards we were quite sure that there was equivalent performance between EBUS versus mediastinoscopy. Yet the guidelines had remained that if EBUS is negative, we go ahead and do a mediastinoscopy. So would you prefer to do a EBUS? And suppose if EBUS is negative, would you go ahead with a mediastinoscopy, Dr. Goel, or would you stop at EBUS currently?
Ma'am, I think EBUS is sufficient for me, I think.
Next slide, please. So as per 2023, the non-inferiority trial which came, it showed that there is no compromise on the survival or the positivity of the nodes. So now it has been concluded that we can omit easily confirmatory mediastinoscopy if it's a negative EBUS. So yes, nowadays EBUS should be considered equivalent, and enough if it's negative, it can be considered negative. Next, please. This is ECS guidelines. Next, similar to what you just said. So EBUS is doing. Next slide. So this patient EBUS N2 was negative. Mediastinoscopy was not done. Next slide. We did a PFT which was borderline. DLCO is 42.5. 6-minute walk test is okay. Breathlessness he has on 1 floor climbing. Borderline PFT FE1 was around 45. Cardiac functions were normal. He has history of angina, so we got a stress troponin test done, which is okay. And creatinine with bilateral renal stents is normal. So now, sir, would you do a SBRT or would you go ahead for surgery?
I think, ma'am, first ball in the court of the surgery, the ball in the surgery. So
The presenter is a surgeon.
if surgeon is comfortable with every fitness, so definitely we can go on this surgical aspect first. If surgeon is omitting, we cannot do or surgical fitness is not there, so definitely the other modalities can be used. Opt. Dr. Ananya, your opinion is also.
Yes, sir. Definitely surgery is the priority because cure is better with surgery as compared to SBRT, chances of cure.
I think network.
Issues. Okay. I think this is better.
Yes,
you can hear me now?
Yes, ma'am. Yes,
okay.
ma'am.
Yeah. So we did a PF. Next slide, please. Next slide. Yeah. So now we decided to operate. So the questions was whether we operate them together, or do we operate pulmonary first, renal first, and in lung, what do we do? Vectomy, segmentectomy, and what do you do about mediastinal lymph node dissection, oblique SBRT? Right now, I don't think I have a radiation oncologist here to actually fight with me, I guess. So I would say I will not do a SBRT. I will do the surgery for this patient. Next slide. Since we don't have an argument, me and Dr. Ananya we are very clear that surgery is the best mode and we should not do SBRT unless we are forced in a medically otherwise operable patient. So sublobar resection versus SBRT. Next slide. So the first meta-analysis, which was in 2017, showed that a sublobar section even is compared to radiotherapy, whether it's SBRT or complete due to a sequential radiotherapy, it still lead to better than radiation therapy survival, even 5 years overall survival, which p-value was significant. This was a meta-analysis of 16 studies, which came in 2017. However, this was for stage 1. Next slide. Yeah. Another one, the problem was that just like segmentectomy versus lobectomy, the problem is that there are no prospective randomized control trials. So they were able to do a RCT for surgery, extent of surgery, but as yet we have not been able to actually go on to an RCT to compare SBRT versus surgery, which makes it very difficult to actually say which is better than the other. The one trial which started, the AXOC Z49099, which was abandoned because of poor accrual. Next slide. 5-year follow-up of our NRG Oncology RTOG 0236 trial again said that the recurrence rates are probably okay, a plus minus here and there, 7.3% versus 20% and all that. But the main issues still remain. One is lymph node dissection, and second is undiagnosed nodules in the same lobe. Less of a point, but more is that if there is a possibility of a surgery with mediastinal lymph node dissection, that gives a better chance of cure for patients. Next slide. This I have already mentioned in the first case. Next. He underwent a laparoscopic left nephrectomy and a VATS right lower lobectomy in the same setting because the anesthetist was more comfortable giving him anesthesia once rather than giving him sequential anesthesia twice. The only thing is, did require a 48 hours ventilation period for his body to settle and the kidneys to come back to normalization. He took a little bit of time. Plus, he was a smoker, but he at the end of 48 hours took around 8 to 9 days to go home. Next slide. So there is no surgeon here. Dr. Dipesh, what would you recommend if you have a meet, whether you would do a lymph node dissection? Dr. Ananya, please chip in if you prefer a mediastinal lymph node dissection or lymph node sampling for patients, especially with the T of 3.9 centimeter.
Oh. I'm not aware with the sentinel node sort of thing in lungs,
Dipesh,
so I think dissection should be done.
Ma'am, I think still I am not aware. I think sampling versus the dissection, I think I am not aware.
Yes, sir. Yeah.
Okay, so basically, next slide. Can I have the next slide, please? So there was only one trial which I wanted to highlight, that which showed that why I had put this up, because if there was a surgeon, I could have actually discussed this more. That there are some proponents of only sampling, but in sampling, the thing is that you do the N1 dissection, it's hilar dissection level 10 first. You send it for frozen. If it is negative, you need not do further dissection of N2. You just sample the N1 and leave just like sentinel lymph node for breast. The only thing is that the frequency of the occult N2 disease is just 4% in dissection arm. Next slide. So there was no difference in the overall survival between the but the problem is that a lot of people misinterpret this trial as saying that dissection is not required. Whereas what they were just trying to emphasize is if you're doing a sampling of the N1 nodes as a hilar node, and if it is negative in the frozen, then they randomized the patients and they found there was no difference. So basically N was like the sentinel lymph node for lung. You do that. If it's negative on frozen, you can avoid a complete dissection and morbidity of the patient. But if it is not, you don't have a frozen, or if you are not able to do it, then you should do a dissection completely. Next. Yeah, so this is the guidelines for lymph node dissection. At least 3 N2 stations or a complete dissection as per NCCN. Similarly, the COC says at least 10 should be removed. ESTS says should do all mediastinal dissections with proper pathological dissection of specimen on table. So similarly, basically, जो दिखता है वही मिलता है is the funda what surgeons try to say, whether you should जो दिख रहा है तो हम निकालते जाएंगे तो हमको occult N2 भी मिलते हैं, but it is less if your N1 is negative. Next, I have seen a couple of patients who are N2 positive but N1 negative. Next slide. So this patient was moderately differentiated adeno-CA. Final was 4/2/1.8. 2 out of 14 nodes were positive, which was N1, TTF1 positive, P22, N1, M0. Now, Dr. Ananya, would you do a molecular marker study for this patient or not? Next.
Yes, ma'am. Definitely, I would like to do the molecular markers. It's like PDL1, EGFR, and ALK. These three markers are the basics ones which I would like to do.
I think I am still agree
So
with
in a
Dr.
smoker
Ananya.
who's Yeah, I also agree. I said it for all patients, but I'm just, what do you expect more in a smoker? EGFR positivity or PD-L1s?
My PDL1.
So basically, here we all three agree that to do or not to do. May next, please. Next slide. So basically, do or do not, but there's no try. So we do the molecular markers for this patient, and PD-L1 is Sanjay, that is a proof that you do very well if your PD-L1 is positive.
Yes, ma'am.
So that's about. Yeah. So good. I did not go much in SBRT today because I don't have someone to actually argue it out. But this is a short thing considering I skipped some things to discuss. So anything else you or Dr. Dipesh, anything else would you like to add on to this panel?
No, ma'am, nothing. I think you have already elaborated everything.
I would like to just ask ma'am one question, that how many patients of stage 1A you see in your like day-to-day
Yeah,
practice?
so
Because
I'll tell you, yeah, so this number was very less before COVID hit us in Bombay at least.
Yes.
So I have a paper which got published last year only on the efficacy of CT scans. We have tried to put off a paper and it has got published, the importance of having some kind of screening in our country, because in COVID 1.5 years we operated around 55 thoracic cases, of which 12 were diagnosed because a CT scan was done for COVID. Out of them, 9 were early stage. And there's one senior officers from Goa. There are 2 senior people in Bombay itself who came with actually T1A and 0, and they got cured with only that one surgery. And that was the middle of COVID, and that showed us actually the value of LDCT, but it's very difficult to implement in our country because I think including the cost and awareness, everything under the sun. But we are trying. I'm trying to push a lot of corporates to somehow get LDCT in some health checkup form or something, because 12 out of 55 is not a bad number to get diagnosed early. So yes, it was very less, but we've seen more and more since post COVID.
Just want to ask, what is the number of what the number you have encountered in your OPD for surgery, metastatic versus the operable?
Yeah, metastatic is always more, but around I think at least 50 to 55% now is coming up, which is operable either upfront or NACT followed by surgery. It's a good number.
Okay.
In fact, recently I operated a patient, which was surprising because she had a cystic lesion in the left lower lobe, and the radiologist said, I cannot do a CT cardiac biopsy. It's like a cyst which will rupture. So you go and you remove it. He refused to do a biopsy, and the PET, the CCT showed no signs of pleural thickening and enhancement. Female non-smoker, put a scope in. It was an almost ruptured cyst. Sent it for frozen, positive for malignancy.
Okay.
Had to do a lobectomy, but that is the chances of having, I think females I'm seeing more now. In my practice, I'm seeing more of females who are non-smokers who are CA lung. They somehow are getting diagnosed enough to be operable. It is increasing, but still at least 45% or 40-45% patients are metastatic at presentation, at least my practice.
Okay.
Yeah, Jaipur is a wonderful city, and thank you to both of you to invite me. Thank you, Dr. Goel.
Yeah. Thank you, ma'am. Thank you, ma'am, for enlightening us. So I think wonderful discussion. So I think sorry, ma'am, Sarjan are not here because of they both are in Ooty. So I think thank you, ma'am. Thank you, ma'am, for accepting my invitation and to be part of us.
More than welcome. Thank you so much.
Yeah. Thank you, ma'am. Thank you. Thank you, Ananya.
Thank you so much, sir.
Thank you, Dr. Ananya. Thank you so much.
Thank you, ma'am. Thank you.
So moving ahead, so I think very well discussed this topic, the early in the management of early lung cancer by the surgical aspect. So we will move forward on the second talk. So I will invite Dr. Pooja. She is consultant medical oncologist at CK Birla Hospital, Delhi, and will give her talk on the reinventing adjuvant therapy in EGFR mutated, the early lung cancer. So over to you, Dr. Pooja. Thank you.
Good evening, sir. Thank you for this opportunity. And may I please get the slides?
Dr. Nishant? Yeah.
Yeah, thank you. So I hope slides are visible. And I'll be speaking on reinventing adjuvant therapy in EGFR mutated early lung cancer. Second slide. So, as we know, the survival outcome in non small cell lung cancer in resectable setting needs to be improved. And non-small cell lung cancer, though it represents 80% of all lung cancer diagnosis, the rest being small cell lung cancer, with an estimated 30% of the patients. So virtually only 30% of the patients are resectable at diagnosis, and we hardly see such cohort of patients who are upfront resectable. And global 5-year overall survival rates with resectable non-small cell lung cancer, as we see from stage 1B, again there is a chance of recurrence. Patients who will die of disease or whether the disease will recur is up to 25% in stage 1B. Stage 2, it is approximately 35 to 50%. Percent. Next slide. So, what is the testing recommendation for early lung cancer? So, as we are very clear, then in metastatic setting, we have to do lung NGS testing, and we have variety of gene mutations and targetable gene mutation for which we have a particular targeted therapy. But specifically in adjuvant setting, non-metastatic resectable lung cancer, we are presently testing 2 to 3 gene mutation, one being EGFR, the most common being again exon 19 deletion, and the second being L858R point mutation. Second being PDL1 positive, more than 1% tumor cell, as we have seen the role of adjuvant immunotherapy. And even ALK positive tumors, we are seeing a good role of alectinib in adjuvant setting. So these are the common gene mutation which we test even in patients who are non-metastatic early stage lung cancer. Next slide. So current testing and treatment pattern. So what is the prevalence of EGFR in resected stage 1 to 3 non-small cell lung cancer? So as we can see that 19 deletion, again it is common up to 50% in terms of the subtype. Second common being L858R point mutation, approximately 36%, and the rest being the other compound uncommon and T790M mutation. So approximately 50% prevalence has been seen of EGFR mutation in stage. Next slide. What is the prevalence of EGFR in resected stage 1 to 3 non-small cell lung cancer? And as we can see, the prevalence is 4.3% overall, and in stage 1 being less, then stage 2 1B 2.6, then 2A 38%, then 2B 7.4%, and so on it is increasing. So patients with stage 2 bar 3 non-small cell lung cancer, only 46% patient receive adjuvant systemic therapy. Next slide. So what we can see that in these early resectable non-small cell lung cancer, 40 to 50% of the patients, who remain cancer free, but 50 to 60% of these patients actually recur. That recurrence could be local or distant. So that means it is a huge unmet need, so that we can improve our neoadjuvant and adjuvant settings, so that we can actually improve outcome in patients who underwent curative intent surgery. Next slide. Adjuvant chemotherapy after surgery for stage 1B to 3A non-small cell lung cancer, improved overall and disease-free survival. So we have seen, lung adjuvant cisplatin evaluation trials. There are meta-analysis including 5 most common trial, which has included cisplatin as one of the chemotherapy drug in adjuvant setting. And what has been seen of disease-free survival by approximately 5%. Next slide. So the role of EGFR TKI. So the role of EGFR TKI in adjuvant settings were, that was a old thing. So lot of trials have been done previously, but they were incorporating either the first or a second generation TKI, like the SELECT trial, including stage 1 to 3A EGFR mutation, that including erlotinib, and we have seen the disease-free survival improved numerically 88% versus 76%. Again, RADIANT trial, where erlotinib was compared with placebo after adjuvant chemotherapy, and again there was a clinical meaningful improvement in disease-free survival up to 46 months in EGFR mutation versus 28 months. Same goes with EVEN trial, which is stage 3 EGFR muted, that compared erlotinib versus adjuvant chemotherapy. Again, there was a significant improvement in the adjuvant setting. Disease-free survival improved up to 42 months from 21 months. Again, the CITONG trial, disease-free survival improved in jeftinib and BR1. There was no DFS or OS benefit. So there were trials which were done previously. We knew there are certain benefits because we have seen an excellent overall survival and progression free survival of EGFR second and third generation TKI in metastatic setting, and we wanted to translate these benefits into resectable setting also, because we know that these patients also, despite these patients being in early stages, still the rate of recurrence is quite high. Next slide. So current evidence of EGFR TKI from randomized trials in adjuvant EGFR mutant non-small cell lung cancer improved disease-free survival, but no. And so as we can see, these are all those adjuvant trials. What we discussed in the previous slide, EVENS, RADIANT trial of erlotinib, jeftinib, EVENS trial, and CITONG trial of jeftinib. All these adjuvant trials have actually shown some benefit in terms of disease recurrence, close to 48 to 50%. So almost 50% hazard ratio we have seen, 0.50, and we knew there is some benefit, but the OS benefit was not there, and moreover there was no long term trials, there was no long term studies, long term follow up was also not there. So maybe it require more studies, more follow up, and probably a trial with the third generation TKI. Next slide. Yeah, so why have these data not resulted in a change to clinical practice? Because trial is limited by design, size, and other factors. So the trials are not uniform. The patient characteristics are also not uniform. No OS benefit has actually been demonstrated. And so we are unclear if this adjuvant EGFR TKI actually resulted in cure, or it is just delaying the recurrence. So we do not know whether this is an actual benefit or it is just delaying the recurrence. So we do not know whether this is an actual benefit or it is just delaying the recurrence. The events, or it is actually resulting in a cure. And also we do not know about the exact duration of treatment and what should be the appropriate drug sequence. Next slide. So now coming to the ADAURA trial, So this included patients with completely resected stage 1B, 2, 3A non-small cell lung cancer who were exposed to adjuvant chemotherapy or not. Key inclusion criteria were age more than 18 years, included majorly patient from Japan and Taiwan with a good PS of 0 to 1, and patient had confirmed EGFR mutation exon 19 deletion or L858R point mutation, brain imaging if not completely completed pre-op, and complete resection with negative margin, plus there was certain gap between the surgery and randomization, 10 weeks without adjuvant chemotherapy, and we can actually enroll patients up to 26 weeks with adjuvant chemotherapy. Patients were stratified based on stage, EGFR mutation, and race, and the randomization arm was osimertinib 80 mg once daily versus placebo, and planned treatment duration was 3 years. So treatment was continued until disease recurrence. Treatment completion discontinuation criteria met. So follow-up was until recurrence. Primary endpoint being disease-free survival from stage 2 to stage 3A, and secondary endpoint was in the overall population that included stage 1B till 3A landmark disease-free survival rate OS. Next slide. So ADAURA trial, what we have seen that it improved the disease-free survival it improved disease-free survival in stage 2 to 3A as well as in overall survival up to hazard ratio of 0.23. That means 70 to 80% reduction in disease recurrence or any untowards event. And to be precise, you can see median DFS of 65 months in osimertinib versus 20 months in placebo. So almost 3 times. Next slide. So adjuvant osimertinib has significantly improved. As we know, osimertinib in FLORA trial that it has a very good CNS efficacy and it has actually reduced CNS disease-free survival. Same is also in the adjuvant setting. It has been seen that it actually delayed, CNS recurrences and with a good CNS efficacy. Next slide. So regarding safety analysis, no new adverse event has been seen as compared to primary readout of ADAURA data. We can see, so any adverse effect is 98% as compared to placebo. But the important point is serious adverse events were 20%. Adverse event leading to discontinuation was 13%. Adverse event leading to dose reduction 12%, and dose interruption 27%. So whatever adverse event, discontinuation, reduction, interruption, it is ranging between 13% to up to 27%. And no new safety data event has been observed even in the adjuvant setting, which is which is very important because in lung cancer we know that so the data is consistent with the FLORA trial with no new adverse event. Next slide. So the key point is in order to improve survival, we need to actually identify the patients early and take more efforts. And we should never miss an opportunity to test patient for actionable mutation. This even apply to early lung cancer, especially EGFR mutation. Collaboration, as we know, with multidisciplinary team is quite important because in lung cancer, we need the incorporation of all the branches, including surgical oncology, radiation, medical, as well as nuclear medicine, in order to improve the survival. Next slide. So patients may ask for treatment option for best survival probability. So we should discuss each and every option and we should provide them with the best available data. ADAURA data gives the probability of patients to remain cancer free along with survival benefit. Though the trial is immature for OS benefit because the follow-up was until recurrence. follow-up of this trial is only for 2 years, but in 2 years also, for the disease-free survival, it has actually shown a very good benefit. Next slide. Next slide. Yeah. So only constraint is financial toxicity in adjuvant setting, especially when we are not sure about the OS data. But as we know that lung cancer, even in the early stages, the recurrence rates are quite high, and so if there is some data on any data that improves survival in this adjuvant setting, we should be encouraged to share these data with our patients and give them an option to decide on whether any adjuvant therapy they would be offered to them to increase the disease-free survival. Moreover, with the long-term follow-up data, we'll be more confident regarding this TKI in adjuvant setting if we get some benefit even in OS, but that require long-term follow-up. And we are seeing increasingly more and more, trials are incorporating whether it is adjuvant immunotherapy like atezolizumab or pembro in adjuvant setting to improve the outcomes, or whether it is, ALK inhibitors or EGFR inhibitors, which are being increasingly used from the metastatic setting. Now, these drugs we are increasingly using in early stages or from 1B to 3A, where we know the recurrence rate is quite high, and efforts are there to improve the outcomes in these stages as well. So, thank you, everyone. Thank you.
So thank you, Dr. Pooja. So very well explained. So I think more and more number of data in futures is available to decide the adjuvant treatment options for EGFR positive EGFR mutated early lung cancer. So thank you. So, and for the next topic, I will invite Dr. Ankur Punia. He is Assistant Professor in the Department of Medical Oncology, Shri Ram Cancer Center, Mahatma Gandhi Medical College, Jaipur. So the topic is the navigating the current treatment landscape for the common EGFR mutant non-small cell lung cancer. So over to you, Dr. Ankur.
Yeah, good evening.
Good evening.
So basically I'm going to now discuss EGFR in the advanced setting.
Yeah.
Basically it's kind of an overview of how the treatment started and what kind of newer things are happening in the EGFR field. Are my slides visible?
Yes, yes, yes.
So now, as we know that EGFR was one of the first mutation which was identified in lung cancer. It started with the second line setting. Initially, it was used in all comers. Eventually, we learned that yes, there is a mutation called EGFR in which this basically works, though these TKIs were not developed specifically to target that EGFR, but still, eventually we learned that yes, the EGFR is the main target for this TKI. So it all started with in the second, third line setting, patients who were previously treated. Gefitinib and erlotinib both showed responses. In some sort of patients, they were slightly better in a majority of patients for these pre-treated patients, and it was eventually published that the activating mutation is there in the EGFR, which is actually responsible why these targeted agents work. And eventually that EGFR mutation was identified, based on which there was a response from these TKIs. EGFR is a broad, basically we target the tyrosine kinase part of the EGFR gene, which is exon 18 to 21, most commonly in the 19, exon 19 deletion, followed by 21. And now we are getting more and more of unique mutations because we are doing more and more of targeted or NGS sequencing. All started with IPAS study, basically randomized patients, irrespective of mutation, to gefitinib versus chemotherapy. PFS was not difference in the overall intention to treat population, more or less same. Then eventually we know that EGFR mutation needs to be there. And when we see if patients were divided based on whether they were mutated, then we can see the PFS difference of 3 months, whereas it was not seen that much in the patients who are EGFR wild type. Actually, the gefitinib arm did worse in these patients as it didn't work for these patients. We had more studies from the basically Asian studies, NEG-GA02, and this Japanese study, which showed more or less the same thing, that PFS in the tune of 10 to 9 months with the Gefitinib compared to around 6 months with chemotherapy. So these studies more or less, established Gefitinib. Same happened with Erlotinib, the optimal, the Eurotrack trial showed more the PFS ranging from 13 to 9 months compared to 5 months in the chemotherapy arm. So both these studies basically established the first generation TKI, Gefitinib and Erlotinib as the standard treatment for EGFR mutated lung cancer. Then came the second generation TKI, Afatinib. It was similarly studied in EGFR mutated selective population in Lux Lung 3 and similarly Lux Lung 6. Different chemotherapy backbone, and more or less the same thing. PFS was 11 months in the Afatinib arm, 5 to 7 months in the chemotherapy arm. OS is not changed, as we know, in all the TKIs, because there are crossover in all the TKI arms, non-TKI arms in all these studies. So OS is not significant, but based on this, we are using TKIs for EGFR mutated lung cancer. This is basically summarizing all these trials. You can see the PFS from the first and second generation TKI is around 9 to 11 months, and chemo is more or less consistent around 6 months. The OS was not improved in any of the study. Then came the second generation, I'll say the newer second generation TKI, Decomatinib. Initially didn't succeeded, then eventually it succeeded in the Archer 1050 study. Basically compared Decomatinib versus Gefitinib. And you can see the PFS was improved as well as the OS, because there was no crossover in this trial. So OS was also improved. PFS was in the tune of 16.6 versus 11 months. And OS was improved by around 7 months with Decomatinib. Adverse events we know are slightly higher. Decomatinib, slightly toxic drug, and majority, almost 2/3 of the patient needed dose reduction. But eventually we saw that even by reducing the dose, the efficacy was not hampered, and we can safely reduce the doses for these patients. So with the use of first generation targeted therapies came the resistance mechanism. We identified different sort of mechanism, and around the most common being the T790M with the new earlier generation drugs. That's why eventually we started with targeting the T790M mutation. Other were also seen by different kind of EGFR mutation and different kind of molecular pathways. But majority were basically targeting the EGFR gene only with the first generation and second generation. So as T790M was the most commonest, so we tried to target that with osimertinib, basically targeting this mutation. AURA3 was a second line study for basically T790M mutated patients compared with chemotherapy, and it showed a PFS of 10 versus 4.5 months. And now then came FLORA study, basically getting osimertinib in the first line. It compared with the first generation TKIs, Gefitinib or Erlotinib. We have the data. The PFS was improved as well as the OS was improved. The best PFS for 19 months was seen with osimertinib. Adverse events, they are not that much increase, I will say, compared to the other drugs, and one of the most safest TKIs to use, just like Gefitinib. So now we start, as the more and more osimertinib was used, the resistance mechanism related to osimertinib was studied. So they were either EGFR dependent. They developed one of the most common mutation was C7S mutation. Not that much common with osimertinib, but seen in around 10 to 15%. But major are off target EGFR. Either they were different pathways activated like MET, HER2, and RAS-PIK3, or there were even small cell transformation or squamous cell transformation in 4 to 5% of the population who were treated with osimertinib upfront. So I see basically the same thing, that EGFR around 10-15% patients, and and 10 to 15 had a change in the histology, and around 10 to 15% have other mutation, most common being the MET mutation. So this is more or less guideline say if patient is progressing on osimertinib, there is no only minor progression, we can continue. If there is oligoprogression, we can consider for local therapy like surgery, SBRT or RFA. If there is a CNS progression only, we can consider SRS and tuning. But if patient has a diffuse progression, we have to change to other systemic therapy. This basically tells what I already told. Histological transformation occurs and off target is basically more common with osimertinib compared to the first or second generation TKIs. So now we started combination therapy. So it started with anti-VEGF therapy, bevacizumab, this NAG026 study combined erlotinib with bevacizumab versus just erlotinib. It showed improvement in the PFS, around 3.5 month PFS improvement, though there was not difference in the overall survival. Similarly, this relay study used ramucirumab instead of bevacizumab. We saw more or less the same data, PFS of around 19 months versus 12 months. Again, the OS was not that much improved. The PFS too was slightly improved with this. Adverse events, yes, are absolutely more when we use a combination. Bleeding events were more common, hypertension was more common, proteinuria was more common, liver increased ALT, ST were more common when we combined anti-VEGF inhibitor to TKIs. So next came the combination of combining TKIs with chemotherapy. The two study are the TMH study from Luruna et al. And NAG009 study. Both showed improvement in the PFS, slightly better in the NAG study. And our study from India showed improvement in the overall survival, though the other study didn't show a significant benefit, but still there was improvement of around 9 to 10 months. So yes, this is also option for many of the patients who cannot take second, third generation TKIs or other targeted therapy. Combining chemo with the first generation TKI is a good enough option. So recently we got the data for FLORA-2 in which they combined upfront osimertinib with chemotherapy. Again, it showed that PFS was improved. It was 25 overall versus 16 months. More improved with patient with CNS metastases. It was almost improved by almost double, I would say 10 to 11 months. Not that much of difference in patients without CNS metastasis. Overall survival is still, still not reached, or events have still not reached. Adverse events, yes, slightly higher. Grade 3 adverse event, anemia, neutropenia, and thrombocytopenia are more by using combination of chemotherapy with osimertinib. But if we compare with the other, gefitinib arm, the grade 3 adverse events, 3 or more, were lesser in this arm when we compare to the gefitinib chemotherapy study. So now we got some other combination being tried up front, use of amivantamab and monoclonal antibody along with the lazertinib, again the third generation TKI. This Mariposa study in upfront was compared to osimertinib. Again, we saw improvement in the PFS, more or less what we saw with in the FLORA-2 study, 24 versus 16 months. And in patients with extracranial PFS was also improved with this combination. Safety-wise, more or less, not any significant new adverse events were seen. Yes, skin rashes or skin toxicity was increased because we are using a two kind of EGFR targeted therapies. VTs were not that much increased. It's one of the concern with lazertinib particularly, but they were not that much increased we compared, and they were slightly high. Yes, adverse event lazertinib, more VTs were seen, but more or less they could be easily managed. So then came the Mariposa 2 study in the second line setting, patient who has progressed in the first line on osimertinib in EGFR mutated, the patient was randomized to chemotherapy or chemo with amivantamab or amivantamab plus lazertinib with chemotherapy. As you can see, the best arm was the amivantamab, lazertinib and chemotherapy. PFS was 8.3 versus 6.3 versus 4.2 months. So good PS patients who can take all kind of these drugs in the second line setting can be given this option of using a triplet. More or less same was seen in the intracranial. The PFS was 12 months versus 8 months. Safety wise, yes, they are highly related of adverse event, particularly related because of the targeting EGFR, and VT were slightly again higher in the lazertinib arm. So yes, we have to screen for EGFR mutations. We are now getting more and more options. Different kind of drugs, combination permutations are happening. Eventually, we'll get a newer generation of TKIs, but I think the pathway will go to combination and to choosing the correct patient for combination, in whom to give chemotherapy, whom to give just TKI. So we'll, as newer trials are coming, we'll get more and more molecular data, which will help us to define how to properly use these combinations for these EGFR mutated lung cancer. Thank you.
So just want to ask, so what proportion in your OPDs you are using the first generation, second and third generation? The percentage, ijapitinib versus afatinib or dacomatinib versus osimertinib, the usage.
Out of 10 patients, 9 will take the first generation TKI.
Okay. So still the financial issues?
financial issues the most common. So if I'm giving first generation TKI, I prefer to give along with chemo.
Okay. So definitely you just want to add the scarbopamy along with this gefitinib. So then pemetrexed will continue in this maintenance or only just gefitinib?
With gefitinib plus pemetrexed maintenance.
Okay, okay. So thank you, Ankur, for this talk. So for next talk, I invite Dr. Kripa Bajaj. She is the medical oncologist in the Indo-American Hospital, Hyderabad, and the moderate a panel on the management of uncommon mutation. So over to you, Dr. Kripa. And the panelist is the Dr. Tarachand Gupta. He is the consultant medical oncologist from the Bhagwan Mahavir Cancer Hospital, Jaipur. Dr. Vinod, I think not there, not here. Dr. Anu is also in emergency. Dr. Deepak Shukla, sir, he is consultant medical oncologist from the Manipal Hospital, Jaipur. And Dr. Rohit Swami, he from the Narayana Multi-Speciality Hospital, medical oncologist. I think the Rohit is not here. So
Okay, Rohit sir.
We all three, myself, Devesh, Deepak sir, and Tarachand.
Okay, Divesh sir and
Hi Kripa, how are you?
I'm good sir. I'm good sir.
Yeah, good to see you. हाँ, again.
Same
ये
here
फोटो
sir.
किसका है?
Same.
तुम्हारा तो नहीं है ये फोटो?
काफी दिन का पहले सर लाइक सो वो ही रखा मैंने.
वो ठीक है, ऐसे यंग दिखते हैं लोग ना, चलेगा.
Yes sir. इसलिए 5 years का पहला कल रखा है मैंने.
चलेगा. Okay.
Yeah sir. Sure. Sir, shall we start? So Divesh
Yeah.
sir is there, Tarachand sir is there, Deepak Shukla sir is there.
Yes.
Yeah. So can I request people to share the slides because I'm joining from mobile.
Dr. Ankur, can you participate? Start, Dr. Kripa.
Yes, sir. So, yeah, can someone share the slides?
Nishant?
Hello,
Nishant, please
Yeah.
share the slide.
ma'am. You will not share with us.
Because I'm joining from mobile, so that's why.
You don't share the slide with us.
No, the same slides which you are shared with me, the same one.
Okay.
So, the management of the uncommon EGFR mutations in NSLC. So, next slide. So usually this is the spectrum of mutations in the NSCLC. We all know adenocarcinoma consists of 55% of the lung cancers. No need to introduce that. And also EGFR sensitivity mutation in India, in South India, it's almost like going up to non-smokers going up to 40 to 50%, I would say. So with this, not just these EGFR mutations are all common. Exon 19 or exon 21, like exon 20 different mutations are there, and also uncommon mutations of exon 19 as well as 21 is also coming up. So today our discussion is regarding uncommon EGFR mutations. So once the patient walked into our place, like how we are going forward. If you see the spectrum here, EGFR, other mutations, MET mutation, HER2 mutation, ROS, BRAF, RET, all these things are there which are considered less than 5%. I would request to Dr. Tarachand sir. So how many patients of yours had, other than EGFR, non-EGFR mutations you have seen? ALK EGFR chhod ke, like how many people you have seen who are having other mutations, even KRAS also?
Yeah, Kripa, if we talk about that, the KRAS, only one patient till now. And ROS1 patients, only 2 patients till now. MAT amplification, only 2 patients till now in last 6 years. 2 or 3, I think. And RET patient, I did not see in lung, just in GBM, I saw that. And other uncommon EGFR mutations, only one exon 20 insertion and one is uncommon EGFR.
Okay,
Blah, blah, blah.
Okay. So what about RAS, BRAF, RET2 and everything, sir?
And, unfortunately, I have not seen any BRAF positive patient. in lung or even in melanoma.
Okay, you haven't seen.
Yeah,
Divesh sir, I would request you to share your experience regarding uncommon, not non-EGFR mutations, I would say.
So yeah,
EGFR, ALK, like a BINA, like whatever mutations you have seen, just please share the experience with us. What percentage and what mutations you often see other than
so
EGFR, ALK?
yeah. So definitely I have seen the HER2 one patient, BRAF two patient, and I think KRAS is also three patient I have seen. Other than the EGFR,
Okay,
rest I have not seen.
okay, you have not seen. Okay. Sir, other sir, other
Dr.
sir's
Deepak.
names are like, what about like
Yeah.
Dr.
Deepak sir,
Deepak.
Deepak Shukla sir.
So
Sir,
Rohit
can
is
you
also
share your
there.
experience?
yeah,
Dr.
so
Rohit.
it is similar to what Dr. Tara, Dr. Devesh mentioned, but again, recently, means around 6 months back, I saw a patient with EGFR and HER2 mutation, both occurring together. I've seen I think 2-3 patients with BRAF mutation, MET mutation, um, both amplification also and exon 14 skipping mutation. I have not seen NTRK, KRAS G12C again. Particularly, I don't remember the percentage of G12C, but as such, KRAS mutation is very common. G12C, because we do not have the drug available with us. So, but again, as you have rightly mentioned, majority of the patients who are non-smoker or male or female, majority what we see is EGFR mutation. Even I'll say ELK is also not common. It is uncommon as according to what I see in my practice.
Okay, okay, understood. So
Dr. Deepak,
whatever,
sorry. Dr. Rohit is also joined.
okay, Dr. Rohit sir.
Yeah, Dr. Kripa, I agree with the other panelists. I had also seen KRAS mutation 2 or 3, two BRAF mutations, and yet not seen any MET amplification.
So KRAS, when you
Uh,
have seen it like concomitant with EGFR, you have seen, or KRAS alone you have seen, sir?
alone.
Alone. So are you
Yeah.
acting in the first line? Or are you reserving your sotorasib or something else like in the second line?
Actually, at present in the second line. At present
Second
in the
line.
initially going for chemotherapy.
Great. So coexistent mutations, you are not going, it's just prognostic. That's it, right? You are not going to use it in second line also, just prognostic.
Yeah.
Great. Next slide. So it's a typical case like what I'm mentioning, this case from Dignity 1. So 63 years old female, non-smoker, no uncontrolled comorbidities, ever with the cough, shortness of breath, and there is a multiple lung mets, pleural effusion got noted and found to have a pulmonary adenocarcinoma. Next slide. So this one, I want to understand what kind of test we are doing and in Jaipur. So DNA-based broad panel NGS test, RNA-based broad panel test, or any other. So what panels we are using? I just want to understand across the country. Dr. Tarachan Gupta, what panel you're, sir? What panel you're using, sir?
DNA-based broad panel NGS we are using.
You're not using RNA-based one.
Yeah, I think RNA DNA मुझे याद नहीं है, but मेरे ख्याल से DNA I don't know.
Divesh sir, what about you, sir?
I think still DNA-based broad panel NG sequencing.
So RNA you are not at all including in along with the DNA.
Yeah, we are including the RNA-based. I think 2 or 3 mutations we are including. So I think DNA RNA mixed base broad-based panel NG sequencing. Yes.
Yeah, so we are doing at Manipal. We are doing it with Dalpet. So initially, I think it was Novartis that came up with the coupon with this both DNA and RNA NGS of 12 gene. So we are doing that 12 gene panel, which is both DNA and RNA based NGS, and in addition, we do PDL1 also. Only one question I wanted to ask: where means suppose in a patient, if you get a diagnosis of non-small cell lung cancer, where do you straight away go with the molecular test, or you do some basic IHC and then go for NGS testing?
Yeah, sir. It was like previously when we were students, we used to do the ALK IHC and hot spot mutations. We used to do it. Right now, with the availability of a lot of coupons from various pharma companies, we are like straight away sending for the 12 broad gene panel, 16 broad gene panel plus speed one. Accordingly, we just selecting. That's it. We are not just doing one basic IHC or something. But usually the TAT of IHC ALK is like very, I mean, just 2 to 3 days. When patient is a non-smoker, when patient has a brain mets in the baseline, I do really incline to start to do the ALK IHC in the very beginning, so that in 2 days I get the report, I can start the treatment also, I can avoid radiation also. Apart from that, usually I'm waiting for some time unless brain mets, I mean, nothing alarming, I'll just wait for NGS report. That's it.
So just means my experience is, as we previously discussed, that majority of our patients are having out of this profile of patients who are non-smoker, female or male. So majority of these are EGFR mutation. So one of the challenges means I have a patient who came out to be ROS fusion positive in NGS, but she had brain met. She expired 1 to 2 days prior to when the report came. So that is a challenge in my practice. Particularly, I remember around 3-4 patients who were having leptomeningeal mets. I personally send ddPCR from blood for EGFR. The report comes in 2 days, and my preference is to start osimertinib once I get the report. So this has helped me, means because the patients are very apprehensive when they are initially diagnosed. It is a challenge for a patient when we are saying that patient is having brain mets. We are going to wait for 2 to 3 weeks, 2 weeks for the report to come. So this is one of the experience that I had with sending ddPCR. The reports come in 2 days. Around 3-4 of these patients went on to receive osimertinib.
So you send EGFR as well as ALK both?
Yeah, no.
Right.
What means, as I mentioned, that in my clinical practice and as such, we know that most common mutation is EGFR. Okay, so particularly if a patient presenting with leptomeningeal mets, I think as such, if we look into the overall incidence, EGFR would be the most common mutation which we are expecting. So I have sent ddPCR, and possibly ddPCR from blood has a good sensitivity. So means some of these patients turned out, means their report came out within 2 to 3 days. And one of the surprises was one of the patients, I sent ddPCR from blood. Her T790M mutation came positive. She was a female non-smoker, and the NGS that we sent from biopsy and later on from the blood also, that came to be negative for any mutation. Okay, we gave that patient, because of her performance status, osimertinib, and she was able to survive close to 18 months. Not 18 months, around 12 months. Means so this was a rare presentation, baseline T790M detected on ddPCR, and both the NGS from the tissue as well as liquid biopsy just we sent to confirm, because baseline T7090M, though I retrospectively reviewed it, it can be there in around 1% of the patient. But this is one experience that I particularly find helpful in clinical practice.
Okay, great. And this is a really value addition to our knowledge, sir. Thank you so much. And also, Rohit sir, anything else you practice, sir? Like, what's your practice regarding the lung mutation testing?
Yeah, I also go ahead with the combined DNA and RNA based NG sequencing in all the patients.
Okay. You're using coupons, or you're having in-house panel, sir?
Yes, no, I am using coupon, not in-house panel, but using coupon, and coupons are associated with core diagnostic and med genome and other. So I am sending both of these, DNA and RNA based in this sequence.
Right. Okay. Divesh sir, what about you, sir? You told like you'll use both DNA and RNA.
So I think we are using the coupon based. So the panel based, the coupon from the core as well as the med genome and the various other labs. So I think they are doing both DNA and RNA based broad panel NGS.
Very well taken. Next slide. So the EGFR epidemiology, just want to understand. So this is a broad spectrum of EGFR epidemiology. So what kind of mutations we usually see? The rare kind of mutations, like how often we have seen in a clinical scenario. Dr. Rohit, like how often you see the rare EGFR mutation? Or you're like only just you're seeing most of the times 19, 21 and all?
Most common are 19 and 1, but still definitely I will say 4 to 5% of these EGFR mutations comes out to be rare mutations.
Divesh sir,
Like,
just to Yeah, rare mutations
I
you do
think
see.
I observed only 1 to 2%, 1 to 2%.
1 to 2%. T790, how
Yeah.
often you see, sir?
I think I have seen recently within 2 months, 2 patients I have seen. So I think the proportion is still as Dr. Deepak sir said, only 1%. So I think I have seen 2 patients in last 2 months.
So EGFR predominantly located in exon 18 to 21. The specific EGFR mutation identified is important. Sensitive mutations, primary resistance mutations, and de novo and acquired resistant mutations. All of us know as the time passes also there can be resistance to EGFR and the exon change also can happen. So even the patient was like initially exon 19, we know that it may turn up into exon 20 mutation as well. If the patient is osimertinib, like we really can't do any change. But if the patient is not on osimertinib, then there is a fair chance for the patient to convert from first generation to second generation. Or some EGFR mutations are sensitive to the first generation, or some dacomitinib based one. So that's a very rare scenario. Let's go through some questions like in this scenario. Next slide. So it's an overall view is this one. So atypical uncommon EGFR mutations, including 6719X and L861Q, S7681. Some are sensitive to traditional EGFR inhibitors. More studies needed. But exon 20 insertions are resistant to traditional EGFR inhibitors. New drugs got approved. So this exon 20 insertions, all of us know amivantamab is a good drug. We all have some clinical trial experience in the major centers. So, anyone has an exon 20 insertion experience, and what is the role of amivantamab? Like, how good response you have seen? Dr. Divesh sir, can you please throw light on this?
I think I have seen just one or two cases, but I have not treated this with this amivantamab. So I have no clinical experience, but I have seen 2 cases.
Right. 2 cases you have seen, but you haven't treated with amivantamab. You just treated with pemcarbo.
Yes. No,
Rohit
no.
sir, no. What you use sir for that exon 20 insertion?
So I think I have not treated because the patient is not fit for further treatment.
Okay.
And
Okay.
patient are not willing for the chemo as well as the other agents.
Great. Rohit sir, so have you seen exon 20 insertions in your practice? If yes, is there any possibility
Yeah, I
or
had
any
seen around
experience?
I had seen on around 2 to 3 and treated with PEM carbo and afatinib.
So afatinib used.
Yeah, used in one patient, and
Okay, did they
we
respond,
had
sir?
yeah, she responded.
Okay, great. So, Dr. Tarachan, sir, you
Kripa,
busy
as
vast experience.
I have already told you that I have seen only one patient exon 20 insertion, 1 or 2 other rare mutations, EGFR only till now.
That
In
one
last
patient,
6
what you
years.
treated, sir? How you treated that single patient of exon 20 insertion? How you treated? I want to
He
understand that.
he was planned for the second line amivantamab, but before that he left me.
He left you or he left the world?
Yeah, no, he left. He did not. I don't know what happened to him, but he did not come to me again after the progression on first line.
Okay, so you used pemcarbo. So, but you didn't. No one used amivantamab now. Sir, Rohit sir used
No,
afatinib.
not used amivantamab yet, but yeah, use
Afatinib, I
afatinib.
meant saying, yeah.
Yeah.
So
Divesh sir.
I have also not used. I have a patient means she was around 1 liter of oxygen. Her report came. Ultimately, we called her for follow-up. She had expired by that time. So means
Okay.
again, one of the challenges with doing NGS is means some of the time we do not want to start the treatment. Some of these patients are not fit for chemotherapy. So we wait for NGS, possibly waiting for some targeted mutation that can come. But we definitely lose few patients during this waiting period.
Understood. Great. Any other inputs you want to add on this one regarding exon 20 insertion, which constitutes 12.8% out of all the lot of uncommon EGFR mutations, or whole EGFR mutations?
One
the
of the
uncommon.
options, yeah, for one of the options is osimertinib 160 milligram. That is one of the options. Suppose a patient both drugs, even osimertinib giving at 160 milligram is very costly. Amivantamab is also very costly. We previously had this mobocertinib and those have been withdrawn. So possibly OC 160 and amivantamab are the two most active drugs that we have.
Great. Next slide. So the somatic mutation status and solid. So liquid and solid, I just want to understand how common you send liquid biopsy also along with the solid biopsy. So what's your opinion regarding liquid biopsy, sending in a lung cancer patient? There is a data coming up for concurrent sending of the solid NGS as well as liquid NGS. Dr. Deepak sir, please tell me.
Yeah, so again, as previously mentioned, ideally at baseline from the block, we do both DNA and RNA NGS. In a particular profile of patient like this patient who was a female non-smoker and any male non-smoker in a given background, we always keep on searching for a mutation. So even though our biopsy maybe means NGS from the biopsy is negative, possibly one of the circumstances where I may counsel for doing a liquid biopsy even if the NGS from the tissue is negative, possibly this profile of patient where we see these type of mutation, possibly one of the circumstances is to do at that time, and also possibly after first line treatment with osimertinib. So we know T790M, but we know other MET exon 14 skipping mutation, and some of the time doing a repeat biopsy. Most of the time patients do not agree. Possibly in those in that setting, I'll go ahead with liquid biopsy.
Okay. At that setting, you'll go for liquid biopsy. Okay. Sir, Rohit sir, did you see, do you really send liquid biopsy also along with the solid, or you want to send only solid? Or if solid is like negative, you want to send liquid? Just you want to continue the same pattern what Dr. Deepak Shukla has said, or you want to have any other thing to add on?
Please unmute Dr. Rohit.
I'll prefer to send both solid as well as liquid NGS at the same time so that anything is missed in the solid NGS and can be picked out in the liquid NGS, and the time interval will be same. But at present, if I am having a block, I am sending most of the NGS on the block itself.
Understood. Sir Tarachan sir, how you want to practice like both?
Usually we are sending NGS on biopsy block only, and sometimes we tried that in a 1 or 2 patient for liquid biopsy, but some labs told us that they can do only EGFR on liquid biopsy, not other mutations. So this becomes very difficult. So we usually send only on the biopsy block. And
non-smoker patient biopsy NGS is negative. Will you send liquid biopsy, or you just want to start chemotherapy for her, plus or minus immuno?
Yeah, I will start chemotherapy.
You will not send again liquid to reconfirm it's a negative?
No, I don't send you.
No, it is not like we can means what I was trying to convey is we if a biopsy NGS is negative, we can start with chemotherapy, and meanwhile just on at the back of the mind we can always discuss that. Means possibly there is whatever percentage, let's say 5-10%, there is definite chances we can pick something on the liquid biopsy. One more point, sometimes patients do come to us when they have done EGFR by PCR and IHC for ELK, means previously what was practiced doing single gene testing. So in my personal experience, I've seen patients who have done these patients, once we do NGS, some of them do have EGFR mutation that was missed on PCR.
Understood. So there's a compound mutation report is here. It's a mutation detected in exon 20 as well as 21. So how you want to take this one? Here it is, it's like this is not T790 mutations. So how you want to treat this patient? Next slide. So would you be interested in period status of a patient who is like positive for EGFR mutation? She's having compound mutation like exon 20 as well as exon 21 mutation is noted. It is not T790 mutation. So patient is affordable. All of us we are really inclined to do the osimertinib alone. Like if it's not so, we'd go for the first generation TKI. So in EGFR mutation patients, will you do PDL1? Divesh sir?
I think we are sending the combo panel along with all mutation panel. We are sending the PDL1 status. So I think there is no need to separate, but we are sending the both samples, PDL1 as well as the targeting all these mutations.
So you want to reserve the second line, like the regimen is there, like where IM power trial is there. So where we want to add atezolizumab, all this further stuff you're doing, or you're just doing like as a combo you're doing.
We are doing, but we can reserve in the second line also. We can reserve.
Right. And also, I showed the compound mutation of exon 20, exon 21. Sir, have you come across any such case with compound mutation, and what's your experience regarding the outcome? Usually, when there is a compound mutation, it was known that patient will not do as good as the patient who are having single mutation. And though we use osimertinib also, there is a high chance of likely to have a less PFS. So, did you have any such case which has a less PFS? The response is not what you expect for a just regular one.
No, I have not observed these type of cases, but I have observed even if EGFR single positive or PDL1, I have not encountered any such cases.
Okay. Rohit sir?
Yeah, so as Devish sir said, initially only we send all the NGS as well as the PDL1 testing. But if the patient is having a rare EGFR mutation like insertion 20, which is not so much responsive to TKI, then definitely in those patients, I like to explore the option of PDL1 also and option of chemotherapy or addition of immunotherapy with chemotherapy. So if I hadn't done PDL1 on the baseline, so in the rare mutation patients, I will definitely go to look for PDL1 status of that patient.
Okay, great. Next slide. So for this patient, what will we plan? So there are two mutations are there, exon 20 as well as exon 21. This is a compound mutation. What is your choice? Tarachan sir, only osimertinib, or you want to add something else like TK plus bevacizumab, like ERLO plus ramucirumab?
If this is exon 20 and 21 both are there, then we can give osimertinib, or we can go with the FLORA2 like pembro carbo plus osimertinib in this case.
Pemcarbo osimertinib, you want to get patient is fit enough.
Yeah. Otherwise, because this is the this patient is going to worse later on and will relapse very soon. So it will be better, in my opinion, to take care with the chemotherapy along with the osimertinib. And osimertinib will be the best choice for the both mutations.
Yeah, I do agree with you, sir. The FLORA2 is a really blockbuster, I would say, because previously all of us used to have experience on Pemcarbo plus gefitinib, but osimertinib with chemo.
Yeah.
In patient
if this patient is PDL1 is also positive.
You want to add what? You want to add immunotherapy also?
Yeah, no. I am just asking if it is this is PDL1 more than 50%.
No, then the driver mutation positive. Yeah, driver mutation positive. Even though it's a 50% more is there, the response will not be really good with the addition of immunotherapy.
Yeah, even in second line, this is not better. So that's why I prefer immunotherapy in third line. In these cases, after the TKI, and continue the TKI with chemotherapy in second line, and then go to the with the immunotherapy in third line, because there is strong data that immunotherapy is going to do worse in these cases in second line.
Okay, Rohit sir.
Yeah, definitely. I'll also like to go with osimertinib and chemotherapy in this patient. And if the patient is not affording, or if you see my second choice, so my second choice will be afatinib, because it helps in the these rare mutation insertion 20 as well as on the 21. So these are my options.
So actually, I'll like to add something. So for FLORA2, we do not have any data for rare mutation. So only patients with exon 90 and L858R patients.
Yes.
Okay,
yes.
so
but still, FLORA2 has shown that there is a compared to osimertinib, like combination of chemotherapy, just like Tata trial, there is a benefit is there. For compound mutations, all of us know that osimertinib alone or TK alone may not be really great drug. If ever we want to add on the benefit of chemotherapy plus both worlds, best of both worlds, I think that's a better combination. I would definitely, I will certainly prefer that combination.
But we do not have data for that. Okay, so
Yeah,
what
data nahi hai,
we
but
have,
it's a very practical
yeah,
to
but
implement that. Yeah.
what data we have is for best data is for afatinib and possibly a Korean data of 30 odd patients for osimertinib. And again, these mutations are rare. Whenever we see, we should go back. Even these three type 2 mutations that are there, they have different sensitivity towards afatinib and osimertinib. The particular mutation what this patient is having is possibly more sensitive to afatinib as compared to osimertinib. And for EGFR mutation patients, they may have a very high PDL1. So again, that is not the driver as already mentioned. So particularly for me, I'll go with afatinib in this case. Definitely option of pemetrexed, gefitinib or pemetrexed, osimertinib are good option. But again, we do not have data in this rare mutation. So we do not know how they'll will they do better as compared to afatinib. I think the comparator arm in that case would be afatinib rather than gefitinib, or let's say osimertinib. For this
Okay, sure.
mutation with EGFR with this rare mutation.
Right. So Divesh sir, for the
Dr.
compound
Kripa,
mutation, you
sorry,
want to go for, yeah, sir.
sorry, last
Someone
2
is
minutes.
talking.
Okay.
Yeah. So we'll close up with your opinion, sir. For the compound mutations, you want to go for FLORA2 regimen, just like Dr. Deepak told, because data is not there in that, you want to go with the single agent osimertinib or afatinib like that.
I think there is the 2 opinion, chemo plus OC versus afatinib.
I will vote for chemo plus osimertinib because compared to afatinib, osimertinib is a better drug for sure. And also only some mutations have a affinity for the afatinib. So if ever I want to really add on because I know the compound mutations will not do as great as regular mutations with osimertinib. I'll certainly
for this case, you have given a case for this particular mutation. We are discussing the answer. It is not general.
Right.
Okay. This particular case, I think we don't have any data for rare mutation of with osimertinib with pemetrexed carboplatin. We are already discussing whether we should for exon 19, 21, should we go ahead in all patients with the combination of FLORA2. This is a totally different patient. Okay, this is a rare mutation with in EGFR. So in this particular setting, do you have any data? See, the means it is exciting, it could work. That is a different issue, but we do not have data for.
I'll certainly, though I know osimertinib compared to single agent combination is better, and pooling up of a large data for uncommon mutation is really rare because it's a few percentage, I would say. So because I have a data regarding exon 19 and exon 21, definitely I'll replicate that in the uncommon mutation because certainly I know single agent osimertinib is really not going to better bet. So that's why I will add because I'll replicate the same because doing the pooled analysis in such scenarios like not at all going to be possible in near future also. So that's why exon 20 insertion is also like at least better than this compound mutation, having compound mutation. Indomercan, when we analyzed only in the large data, we found only 3 cases having a compound mutation, only 3 cases in the thousands of patients. So if that large data is having 3 patients across the India also, if we collect, it's really hard to get patients to perform a trial. It has to be pan-global trial, I would say. But replicating the data from exon 19 and exon 21, definitely, certainly, because osimertinib is going to work in all the 3. So why not we club the chemo and this one when we know that the response will not be as good as a single mutation. That's what my take. Though the data is not there, certainly I'll practice as Dr. Tarachan suggested, Rohit suggested, I also do the same.
Ma'am.
Who is that?
Yes. Ma'am, what your thought on the toxicity of the FLORA2? Especially
FLORA2, right now, the oldest patient
and your
who is
clinical
taking
experience,
FLORA2. Right, I'll add on that. Yes. So right now, the oldest patient who is taking FLORA2 regimen with me is a 72 years old male patient. So he has no toxicities at all. And also the osimertinib what I'm using is not a, I think this is okay to talk in this panel. So I'm not really using the original molecule also. I'm using the Bangladesh molecule because it's not really affordable. So the response after 3 cycles, he got a near complete response. I'm happy with it. In whatever patients I'm using, the FLORA2 regimen, only 1 patient is on the Bangladesh, rest 6 are on the original one, AstraZeneca one. And all 6 got a very good partial response. This guy got a near complete response because this budget is not so great, actually, not so high. But because he's a really fit guy, I really tried. He's an army man. That's why I tried this one. So the response is good and toxicities are really not high. Just like Jeff study is there in TMH, it's almost really the same. It's not really high. It's really well tolerated in my practice. I would like to take a opinion from all the people who practice the FLORA-2 trial. Is the toxicity really high? You found it, or you found it's like really manageable and it's okay to sort it out?
See, I will, in my practice, FLORA-2, I'll use for patients who are young, having brain mets. Possibly the best data to be used is for these patients. Across spectrum, I'll change my practice to FLORA-2. Again, it is means we do not have OS data. So particularly in a patient with
Data trial has shown recent update also there is a significant OS data is there. There's only Gefitinib based one.
Yeah, but for TMH, for this OC with the pemetrexed carbo, I think presently in my practice, I'm choosing for these patients. Possibly down the line, obviously we do not have much options. So possibly down the line, as the data matures, I'll change my practice to all of them. But presently, I'm doing for patients who are having brain mets or possibly younger who can means. Down the line, even with pemetrexed, Gefitinib, I have seen renal toxicity. Means I have 2-3 patients down the line whose creat start to worsen to, and I think all of us will be having, we have to withdraw pemetrexed and continue with Gefitinib alone, even with TMH, the protocol that we use.
Tarachan sir and Rohit sir, who voted for FLORA-2 and who saw the evidence of PEM plus GFGC with a very good outcome and less toxicity. What's your take on FLORA-2 trial? What's your toxicity experience?
Yeah, toxicity is manageable. That's not so much toxicity with the combination of osimertinib and PEM carbo. And at present, 2 patients are going on and they are fine. Matlab that there is no much toxicity with the PEM carbo and osimertinib.
Okay. Rohit sir, Tarachan sir.
Yeah, toxicity, I think osimertinib is a wonderful drug. I did not see patients who are having more than grade 1 diarrhea or grade 1 rash with the osimertinib like other TKIs. I have not seen the patient like that. So toxicity is manageable, and with the PAM carbo plus osimertinib, I have not used that. But I still that if the patient is coming with PS3 and patient is treatment naive of lung cancer, patient can be fit by only single agent carboplatin. So I think within 7 to 15 days, patient becomes fit for the PAM carbo plus osimertinib because osimertinib itself doesn't give toxicity. And third thing, in my opinion, that we cannot have the trial for each time, each mutation. If we know that the osimertinib, if osimertinib is PAM carbo plus osimertinib is better than osimertinib in the indication approved for the osimertinib, then I think where we are using osimertinib, we can use PAM carbo plus osimertinib as a FLORA-2, as this can be extrapolation of the data only. So it is not possible that every time we will collect that rare mutations and common mutations including. So this is my opinion. And otherwise, I think rest are same. But still, I am not using with PAM carbo plus osimertinib because it is difficult to counsel the patient if he is having or she is having positive for the driver mutations. Please take the chemotherapy also.
Right. Wonderful. I think it's time to conclude this panel discussion. Otherwise, Devesh sir will, openly ask me to shut down the screen. So thank you so much for this opportunity, sir. I learned a lot with this brilliant panel discussion by a brilliant panelist. Thank you, sir. Thank you so much.
Yeah. So thank you, Kripa, and thank you, Deepak sir, Rohit, Tarachan. So I think wonderful discussion. So I am not, I have learned many things from this panel discussion. So thank you, Dr. Kripa, and thanks Deepak sir, Rohit, as well as Tarachan for moving.
Thank you, sir. Thank you.
Thank you. For next session, I will invite Dr. Abhishek Sharma, who is the consultant medical oncology as well as hemato-oncology oncologist at Goel Hospital, Jodhpur. and he will give the talk on the optimal management of EGFR mutated non-small cell lung cancer patient. So I think this is the AstraZeneca sponsored session. So over to you, Dr. Abhishek Sharma.
Yeah, thank you, sir. So most of the after a good panel discussion on the EGFR mutation and most of the slides covered by my colleagues and seniors. So I just try to summarize the management of the EGFR mutated non-small cell lung cancer. We all know the worldwide is the most common cancer in the lung and the most common cause of death in the all sexes, both sexes and all ages is the lung cancer only. So yes, what is the first line option we have? This we have actually for the EGFR mutation. I am talking about the only the common mutation is the exon 19 deletion and L858R mutation. So yes, we have an option of first generation, second and third generation TKIs. Third generation TKI right now is the most common TKI. We use osimertinib for our patients. Those patients who detect with the exon 19 deletion and L858R. So our first line treatment is the osimertinib. And you can see EGFR mutation discovered during first line systemic therapy. Yes, we can interrupt the treatment. We can complete our chemotherapy as we have planned, and we can shift when a patient progression at the physician choice only. So yes, answer is the osimertinib for the all EGFR sensitive mutations. So yes, the patient, those who diagnosed with the same, the strong recommendation by the all panel, all guidelines by the osimertinib monotherapy. Yes, the moderate, moderate recommendation is the gefitinib with doublet chemotherapy. This is most used in the data, mainly this is a data trial actually. Documentary monotherapy with the afatinib, allo bevacizumab, allo ramucirumab, and a first generation and rest second generation TKI we can use, but the most common use is EGFR. So there is some basic pharmacokinetics difference with the drugs. You can see in this charts, EGFR sensitive mutation inverse activity for the first generation. You can see in the second generation, they have some rare mutations work also. And in the third generation, there is sensitive mutations inhibitors as well as T790M mutation inhibitor also. The reversibility, yes, first is a reversible, second is a irreversible binding, third one is a irreversible binding. Targeting reversible binding of the EGFR ATP binding site. For the second generation, they are the covalent modification with the ATP binding site or the EGFR cis and HER2 cis site. For the third generation, there is a covalent modification of the ATP bindings of the EGFR cis mutation. Yes, able to do cross blood-brain barrier. First is very minimum, second is minimum, and third is significant. And in the first generation is EGFR is gefitinib allotate, second is afatinib, and third is the osimertinib. This is a monoallylinopyrimidine chance. So you can clearly see they work on a 19 deletion and L85821 and as well as the T790. Inhibition on T790, lower activity against the wild type, but crosses the blood-brain barrier is a preclinical as well as the human studies. So first trial that is published in the metastatic setting, this is a FLORA phase 3 trial. They randomized first generation Jef-Arlo versus osimertinib, quite well missed inclusion criteria, and stratification done with the basis of the exon 19 deletion and 21 deletion as well as races. Crossover allowed. Primary endpoint by the PFS, secondary endpoint by the OS, as well as subset analysis with the response, duration of response, safety analysis. The PFS, you can clearly see there's a good PFS benefits, 18 versus 10 month, good hazard ratio 0.46 and significant p-value. And this is powered for the PFS only. And you can see in the subgroup analysis, excellent forest plots favor the osimertinib with the excellent hazard ratio in all subgroups. You can see the over OS analysis. You can clearly see good maiden OS survival. You can see the 2-year survival 60 versus 74% in the osimertinib. Median OS is more than 3 year. Osimertinib patient will more likely to be alive at second and third year. This is the landmark part for this trial. First time an EGFR TKI translate PFS into the OS. This is the first TKI that translate PFS to OS. Safety analysis, you can see. This is the part where the 28% of patient is still receive 3-year osimertinib compared to the comparator arm. There is only 9% patient receive the other treatment, and 22% and 5 in the osimertinib arm patient receive treatment after the data cutoff, and 5% in the second arm. So you can see there is a more chances of subsequent therapy in the osimertinib. And this is the time to first subsequent treatment. You can clearly see osimertinib has a good value. There is a event is quite good. So yes, osimertinib patients have received subsequent treatment is later, but compared to the other TKI. So yes, this is the first line. Gefitinib PFS around 1 year. You can see erlotinib around 13 months, afatinib around 11 months, and 19 months is around osimertinib with the FLORA trial. And yes, PFS and OS is supplement in the all subgroups. You can clearly see in the forest with the good hazard ratio. Yes, so that OS benefit in subgroups as well as intention population favor the osimertinib compared to other TKI. Then right now, just little bit about Indian data about the first line TKI with the 1 year PFS around 6 to 8 months, OS around 18 months or 20 months in the all TKIs. So there is some studies that is compared some decomotinib versus osimertinib is the newest one in the TKI. You can clearly see decomotinib versus gefitinib in the ARCA trial versus FLORA. You can see this trial is primary endpoint is the PFS in the both. But overall response rate is the decomotinib study. They powered a secondary endpoint as the overall response rate compared to OS is the secondary endpoint in the FLORA study. They only included patient with the recurrent or non-small cell lung cancers. They are included locally advanced as well as metastatic lung cancers. The exclusion criteria you can clearly see there is in ARCA trial, they didn't include leptomeningeal or brain mets patient, but in the FLORA trial, yes, they include the CNS metastasis patient, those who are stable and those who are not required steroids. So they are a good separation of the curve in the FLORA, start to end. You can see there is a 6 month, there is no separation between the ARCA and trial. Ashok ji, मैं class ले रहा हूँ, वापस call करता हूँ. So yes, there is a good separation of the curve in the FLORA compared to the Archer. There is 6 month separation after the 6 month. So yes, one more part is very important for the regarding ARCA because ARCA is designed for the statistical significance with the response rate. But yes, in a response rate, you cannot statistically significant the OS on the basis on the response rate only. But thus again compared to FLORA is directed to the PFS only. Yes, and significant PFS translate to the comparable OFS. There's a content analysis of the ARCA trial, and this trial, about the trial, they written as a beautiful line. The trial had a hierarchical stratified statistical design, and given that it did not meet the significance in the overall response rate, so a p-value could not given to the OS. And when compared, this is an open label study compared osimertinib is a double blinded study. They include the brain mets and leptomeningeal mets patient. Yes, osimertinib included. Median PFS is good. Separation is quite good. Response rate is good. Median duration of response. Median OS is good. And dose reduction and serious adverse events is quite safety is main part of the osimertinib compared to the decomotinib. There is a complete dose reductions and this treatment discontinuation is more with the decomotinib. When we talk about the Lux lung, afatinib and Arger, yes, afatinib failed to improve OS versus gefitinib in the Lux lung, and same about the Archer. They are designed for the ORR, but OS you cannot basis on the ORR you cannot say it's a OS benefit. So you can say stable brain met patient include 16% in the Lux lung. There is no brain met patient in the Archer. There is stable brain met patient include around 19% in the FLORA, and there is a PFS benefits you can clearly the best in the FLORA trial. And now we talk about the CNS. The CNS penetration with the first generation TKI is very poor compared to the second or third. The third generation TKI has a good penetration, brain penetration. So first generation is poorly distribution in the brain, but the third generation, yes, osimertinib is a good blood-brain permeable, or this is actually proven in some clinicals and in some human study also compared to the other TKIs. So in and the other TKIs, they didn't include the patient, and as well as they didn't subset analysis of CNS metastatic patient. But in the FLORA trial, you can say both systematic as well as intracranial efficacy were analyzed, and osimertinib shows superior efficacy to compared to the erlotinib and gefitinib. Efficacy patient with the brain mets was not investigated in the erlotinib and gefitinib. And Lux lung 3 or 6 studies averted no significant improvement in the systemic response compared to the chemotherapy, and neither study assessed the intracranial response. Yes, so osimertinib is the only TKI that report intracranial efficacy. And you can see the patient with the CNS mets, the median PFS around 15 months, and in those who are not CNS mets, is a median PFS around 19 months. So yes, hazard ratio more or less similar. You can say there is a no significant PFS different also in the patient, those who have a CNS disease or those who have not CNS disease. But yes, CNS benefit also in this trial. And intracranial CNS benefit, you can see there's a clear intracranial CNS benefit with the osimertinib compared to the other competitor TKIs. And yes, PD on the osimertinib is around only 19% compared to the other TKI. There's around 40% progress on the TKI. Or that is a parts, yes. So for patient with the brain mets, you can start with the osimertinib. Leptomeningeal spinal mets, yes, our choice is osimertinib only. Tolerability profile, there is a very good tolerability with the osimertinib. Only 15% patient is discontinued for treatment for any adverse event. Grade 3 event is around 18%. This is quite comparable with the other TKI. This is more adverse event with the first generation TKI. And you can see clearly around diarrhea, rashes, and other side effects is around 1 to 2 or 1 to 3%. This is almost comparable with the first generation TKI. This is less or similarly same with the first generation. So in the Lux Lung trial, you can patient is a dose reduction is more frequent compared to afatinib and gefitinib. In Archer, there is around 66% dose reductions, 41% in the Lux Lung, but only 4% in the Flora. So yes, this is a most tolerable TKI. And when compared to both Archer and Flora, you can see around 66% discontinuation in the Archer and only 2.9% discontinuation in Flora for any serious adverse event. And when you about the use of the analysis of the Archer in the geriatric population, higher incidence of grade 3 and grade 4, most frequent dose interruptions, most frequent discontinuations. So this is a synopsis for the patient. Osimertinib, we thought around 19-month PFS, and after that, all patient receives chemotherapy or any other treatment. But when we talk about the first generation TKI, 1/3 patient received a patient validated for the T790M, and 1/3 patient received TKIs, and 1/3 patient receives some chemotherapy, and 1/3 patient doesn't receive any kind of therapy. So this is the most important, right? Whenever you place a patient on osimertinib, yes, subsequently you can easily plan for another treatment. But when you are start with the first generation TKI, this is difficult to plan for any subsequent therapy because of their loss of their performance status, as well as their progression-free survival is low. So this is analysis and some you can clearly see patient start with the first generation, around 17% patient receive second line, and in that around 60% validated receive a T790M test, only 50% as a valid T790M, and only 2 or 3 patient able to receive is a second line osimertinib. So only 1/3 patient receive osimertinib in this studies. And one more was most important studies, that is starting with the prior generation TKI like afatinib. They start with the afatinib in the geotech study, followed by the osimertinib. So this study will be quite good median OS. You can clearly see it's 14-month one. So geotech study suggested reversing osimertinib for the second line after failure of TKI may result in the better OS. But the median OS for the patient who receive afatinib followed by osimertinib is around 40 months. It's a quite good OS, but this is already have some flaws in the studies. First one is geotech is a retrospective analysis study. They exclude patient T790 negative or not tested. Died on those patient is not included. Those of on a first line afatinib. Geotech endpoints in TTF cannot be compared with the PFS and included treatments beyond the disease progression. OS by the extrapolatory points. Geotech patient had a higher incidence of deletion 19.7 exon mutation. Must have initial osimertinib more than 10 months before the enrollment. Shorter treatment duration were excluded. It is not possible to draw conclusion about a relative benefit of the subsequent sequential afatinib osimertinib versus first line on osimertinib without head-to-head comparison. You have to head-to-head comparison. Otherwise, on a basis of the retrospective analysis, you cannot say this study had a highest OS. Sequencing about the prior generation TKI followed by the when patient develop EGFR T790 mutation, then you have shift to osimertinib. This is not a good approach because you cannot figure out which patient going to be develop EGFR T790. Not everyone will be well enough to receive additional treatment. Tissue or liquid biopsy not always successful. Osimertinib associated with the good survival benefits. This is the real world data. This is the flower data. You can see this is an Italian study. You can clearly see 18-month PFS and as well as the good OS in these patients. And in the real world, there is a safety analysis. You can see it's almost similar to the trial, but yes, thromboembolism were more frequent in real world compared to that published in the study. And this is the Aussie factor study also. This is one real world setting analysis. Median PFS around 20 months, median TTF around 19 months, and you can see the duration of response, overall response, all are good with the real world analysis. So yes, and ossifact analysis, the pneumonitis of all grade was higher compared to the flow trial. So in the real world, there yes, pneumonitis, thromboembolic incidence are quite is higher compared to the flora. Otherwise, all our survival is same. So same with the Mykonos study. So this is the 3 good real world study with the osimertinib, and long-term outcomes will be evaluated with all this study. Yes. So overall, osimertinib is the drug of choice for the EGFR exon 19 deletion and other EGFR mutation patients. Is a good OS, easily tolerable, less discontinuation rates, and the safety profile is quite good. Quality of life patient is maintained. So yes, my choice is osimertinib for the all patient. Now we talk about the FLORA 2 trial. This is a quite still debatable trial. Most of clinicians are using this trial with because the 2-year survival, 2-year PFS around 41% in the osimertinib arm compared to the 57% in the Ossi plus chemotherapy arm. Median PFS around 25 versus 16 months. So yes, we can use that data also FLORA 2. But toxicity is grade 3, grade 4, especially hematotoxicity, AKI, as well as GI toxicity is quite high in the FLORA 2 approach. So whenever your patient is young, fit, without any comorbidities, performance is good at the presentation, yes, you can go ahead with the FLORA 2 approach. Otherwise, the FLORA is the best answer for the EGFR mutations. Thank you.